Welcome to part 2 of Applied Biostatistics. Today we'll be talking about different designs and hypothesis testing. How do you develop a statistical analysis plan, or SAP? Well, ideally you have a statistician who knows that area very well in the boat when you do the designing of your study. You may be very good at knowing about the treatment or the condition or the patients, but we're not as well trained as statisticians in then applying the right methodology to your study question. Ideally, you have a pre-specified statistical analysis plan, meaning you don't look at the data and then you design your experiment post hoc, after the fact. Oh, I need to ask this question because that's what my data tell me. Or let me use a different statistical test because that's only how I get to a p of less than 0.05. That's not good science. So more and more journals actually require a pre-specified protocol being put on an online website or being registered with a certain data repository. You need to look at what are my primary outcomes for my primary analyses, what are secondary outcomes and secondary analyses, and what might be exploratory. You need to look at, do you want an interim analysis or do you only look at the very end? An interim analysis can be helpful for an adaptive design. Let's say you study 3 groups, 2 different doses and placebo, and in the interim analysis you can see that one dose will never make it and you drop it. And then you have basically only a 2-arm design. You always spend some alpha, which is the statistical power, if you've looked already once. You can also look in a blinded way and look whether the variance in the measurement is larger than you thought. Because in order to do a power calculation, which we'll be talking about later, you have to ideally glean from the literature, what is my mean score difference, if I have a continuous outcome, and what's the standard deviation around it. Now, if your standard deviation is smaller, less noise, you need a smaller group. But if it's larger, you will need a larger group to show differences. You also have to think, do I use intent to treat? Everyone randomized is analyzed for everything. Or do I use a modified intent to treat analysis? That's usually done for continuous outcomes, where you use everyone who has at least one treatment and also has received the treatment, if it's a treatment trial, but also has come back at least once for a post-baseline assessment. And you could do that with a baseline carried forward, where you basically take everyone, even if they're not treated, but that obviously assumes as if nobody would have improved at all. You need to plan how to handle missing data. Do you use generally used statistics, which assume that the data are not missing completely at random, but generally at random? Or do you assume actually the dropouts will not be at random, which means you need another statistical method, which is highly sophisticated, and for that you definitely will need a statistician. And you need to think up front, what are my confounders, my variables that might bias the result in one area or another? And then you might also think about measuring moderators and mediators. A moderator is a baseline factor that tells you who will respond or who will react in a certain way, whereas a mediator is an intra-observation, intra-treatment variable that tells you how or why is something changing. So for example, males or females at baseline, who does better, or younger or older people, that would be a traditional moderator. But the dose of an intervention, how many sessions you got of a psychotherapeutic intervention or higher or lower dose of a medication, would be a very classical mediator. Whatever you think in terms of moderators, mediators, or confounders, you need to measure them in order to apply them. Also, in non-randomized observational studies, you need to ask, is your sample frame, how you get patients into the study, actually representative of the overall population you want to test the hypothesis for? Also, If they're not really similar, you might need to use something that's called propensity score matching. So let's assume you look at the effect of a treatment for mortality in people with schizophrenia versus the general population. Well, we know that people with schizophrenia have various factors that make them at higher risk for having early mortality. So those factors need to be measured, and then you get basically a weighting of the score for each person, how much risk they carry, independent of the intervention you want to study. And that also depends then on whether these confounders are actually measured. And you also may have to consider the use of time-varying covariates, let's say co-medications that are in or out at certain periods of follow-up, or comorbidities that emerge over time. There are different study designs. The highest level of evidence is a parallel group design. You randomize to A versus B or A versus B versus C, done at the same time, and the flip of the coin separates them into the different groups. You could do a 2-period crossover where patients get into one or the other group, then have a brief period or longer period without treatment, and then are crossed over. But the problem is there's usually a carryover to some degree from one condition to the next. So this is not considered a high level of evidence. You're saving yourself some patients because the same patients go into both conditions, but it's generally seen as being quite confounded. You could use an enriched design, making the decision to study only a subgroup of patients that are at highest risk for a certain outcome. You could enrich for previous response or non-response. You could look at more severity on your outcome score, for example, as an inclusion criterion to have more room for improvement. Or you could also look at a biological marker. Let's say if your treatment is adding fish oil, then you might want to look at omega-3 fatty acid baseline scores. And if they're normal, then you might not reach much in terms of outcome if you add further omega-3 fatty acids. And then you can do the opposite of randomizing people to be on treatment by doing a withdrawal design. So patients who are usually stable are then randomized to stay on the treatment that stabilized them or come off it in a blinded fashion, and then you see whether there's a maintenance effect that this intervention would have. Randomization is key, as I mentioned already, because it controls not only for known but also for unknown confounders. The larger the randomized group is, the more completely can we say that these groups are similar. Matching is another way where you try to post hoc make patient groups in one versus another condition similar, but you can only match for things you know that are relevant and that are adequately measured before or during the study. You could use a historical group, which is a big problem because they were treated at a different time under different conditions, so that's not a high level of evidence. It gives you more of an exploratory view of what could have been a parallel design outcome. You could nest patients in a control group. For example, they are only in a certain service versus another service, but these are non-random assignments. And as I mentioned before, propensity score matching can help equilibrate post hoc the groups as if you had randomized, but again, only for known and measured factors. What's your comparator? Placebo is one way of doing it. That's not always possible. You could use standard care or usual care, but often that's delivered in different levels and at different centers differently. So ideally you then measure what is being delivered in the control condition. You could use a lower intensity of the same intervention. You could use different doses, no treatment, which is often the waiting list. But that's a problem because it's not only no treatment, it's also on the waiting list generally no study around people. So then the expectation bias that is a placebo effect too, of just being in a study and being surrounded by people who care for you and measure you a lot and having the hope that you may get something, that is all removed. So studying something against a waitlist has usually the largest effect sizes. You could use a historical database, but as I mentioned before, that is fraught with difficulty because there are different ways of care or outcome in that time frame, or also a different area of care. When you test hypotheses, you have to guard against type 1 and type 2 error. Type 1 error is finding a difference when there isn't one. So it's the false positive. Type 2 error is when you say there's a null finding, there's no difference between the group, but there is one, and that's the false negative study. So in order to guard against that, you need to have higher number of patients. Then you may have heard about sensitivity, specificity, positive predictive and negative predictive value. This has to do with a test of outcome when you measure something in the beginning and see whether that is predictive for an outcome at the end. Sensitivity means, can you identify the true positives? And specificity is, can you identify the true negatives? Then the positive predictive value is people who have an illness or response predictor at baseline, does it actually follow through till the end of the observation? And the negative predictive value is the opposite. So something that's absent at baseline, does that predict also absence at the end? This concludes the second portion of our Applied Biostatistics program. In the next one, we'll be talking about power, sample size, and effect size.